Hello, everyone, and welcome to the Children's Cardiomyopathy Foundation's webinar, Management and Treatment Strategies for Cardiomyopathies in Children. My name is Gina Petty, and I am the Executive Director of the Children's Cardiomyopathy Foundation. We would like to take a moment to recognize our corporate sponsors noted on the slide for their generous and ongoing support of our webinar program and work at CCF. Thank you so much. The Children's Cardiomyopathy Foundation, or CCF, is a nonprofit organization dedicated to finding causes and cures for pediatric cardiomyopathy through the support of research, education, awareness, and advocacy. Established in 2002, CCF has grown into a global community of families, physicians, and scientists focused on improving the diagnosis, treatment, and quality of life for children with cardiomyopathy. During today's webinar, questions are encouraged and welcome. You can submit your questions via the question box located in the control panel on your screen, and we'll hold the questions until the conclusion of the talk. You're welcome to submit your questions throughout the presentation as you think of them. The webinar is being recorded and will be available on our CCF website and YouTube channel in the coming days. As we wrap up National Heart Month this February and also recognize today as Rare Disease Day, we are thrilled to be joined by Dr. Stephen Lipshultz to present a special webinar to our CCF community. Dr. Stephen Lipshultz is a professor of pediatrics at the Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo. Dr. Lipshultz has held many leadership positions throughout his career in academia, serving as endowed chair and professor of pediatrics at Wayne State University and University of Miami School of Medicine, and associate chair at the University of Rochester. In addition, he has served as chief of staff at their accompanying hospital systems. He's a graduate of University of Pennsylvania Graduate School program in Molecular, Cellular, and Developmental Biology and Dartmouth Medical School. He completed a residency in pediatrics at Rainbow Babies and Children's Hospital, Case Western Reserve University School of Medicine, and a fellowship in pediatric cardiology at Boston Children's Hospital, Harvard Medical School. His primary research interests are in pediatric cardiomyopathies, especially those of genetic, metabolic, or infections and inflammatory etiologies. Clinical research on determinants of outcomes for children with cardiovascular disease has been a major focus of interest as well. Dr. Lipshultz served as chair of the writing committee of the American Heart Association paper being discussed today, and also serves as chief medical officer at the Children's Cardiomyopathy Foundation and lead of the Pediatric Cardiomyopathy Registry. Dr. Lipshultz, thank you so much for joining us today. We're so thrilled to have you here.
Thank you very much, Gina, and everybody for this opportunity. And I think it's a very special time. As Gina mentioned, National Heart Month, and we felt that of the people that really are involved with the Children's Cardiomyopathy Foundation would really benefit from understanding a little bit more of how a lot of the last more than 20 years of dedication by families that have supported the Children's Cardiomyopathy Foundation have led to improvements in outcome for children dealing with and beyond cardiomyopathies and their families. And since this is certainly a set of rare diseases, this is, again, really timely that it's a Rare Disease Day in addition to National Heart Month. Our research that I'm going to be presenting today has been supported pretty strongly by the National Institute, a variety of other foundations. But as the fourth bullet, I'd like to personally honor Lisa Yu and the Children's Cardiomyopathy Foundation for greater than 20 years with more than $10 million of support. Really effort by families and foundations and others. Some of the advances that have led to the American Heart commissioning us to write this first scientific statement on the treatment strategies for cardiomyopathy in children would not have come to be. So the learning objectives for those of you who are on at the moment is to
Dr.
review the
Lipshultz,
recent,
I'm so sorry.
yeah,
Can you, is it possible to do your screen in the present mode? I think we're still seeing the, there we go. There we go. Sorry. I'm so sorry. Thank you.
yeah. So thank you very much. Is to review the recent American Heart Scientific Statement on treatment strategies for cardiomyopathy in children. And this was published on July 11th, 2023. And again, this is the first American Heart Scientific Statement to focus on treatment for pediatric cardiomyopathy. And the goal of this, which was endorsed by the American Heart officially, is to outline what's currently known and what areas need additional research. The American Heart does not make treatment recommendations with a scientific statement, but it becomes important. And that's why we're doing this webinar on this topic today, that as the American Heart assembled this group of esteemed colleagues in this field that are listed on this slide from around the country, that the dissemination of some of this um, uh, scientific statement results becomes important. The American Heart shared that even in the first week alone, after it came out, 173 published stories um, were there. And, the whole goal is by dissemination, will it lead to greater implementation and help improve outcomes for children and their families with cardiomyopathies. So a little bit of background. Again, I know the audience is mixed when I looked at who registered. We have many families that are involved. We have many providers that are involved. So some slides, you may know all of this information. Some of you, you may say this is a little too technical. So I've tried to balance it a little bit, and there's certainly opportunity in the question and answer period later to address this. So cardiomyopathy in children is a disease of the heart muscle structure and function that makes it harder for the heart to pump blood to the body and can in some cases lead to heart failure and death. And there's several types of pediatric cardiomyopathy, and they can be a life-threatening condition. It affects about 1 in 100,000 children for some of the pediatric cardiomyopathy, but in certain, it can be even more frequent than that. Greater than 50% of children presenting with symptomatic cardiomyopathy, such as heart failure, will, in some of our studies, within 2 years after being diagnosis and resulting in heart transplant or dying a cardiac death. And what we have found in others is 50 to 75% of children with cardiomyopathy have no known cause. Yet cardiomyopathy is a leading cause for heart transplantation from 2 to 18 years of age. So one of the things that my colleagues and I set up in 1990, 34 years ago, was the Pediatric Cardiomyopathy Registry. We recognized that no one center had made tremendous advances from the 1940s to 1990, and that by working together with this set of rare diseases and sharing in real time, we could create what's said there, the PCMR, Pediatric Cardiomyopathy Registry, the largest database of sociodemographic and clinical information on children with cardiomyopathy at cardiology practices throughout the US and Canada. And because of its high quality, large size, and completeness, this database has provided a foundation for many future studies, some of which we'll go over. When we look at this, what we have found and published in New England Journal is about 51% of kids with cardiomyopathy have in the red a dilated cardiomyopathy. We find that in the blue, 42% had hypertrophic cardiomyopathy. We found that 3% of kids with cardiomyopathy have a restrictive and 4% have others, such as rhythmogenic. Again, for many of you, you're very familiar. The symptoms of cardiomyopathy in children may include difficulty breathing, heart palpitations, fainting, limitations of physical activity, swelling to the ankles, feet, legs, abdomen, congestion in neck veins, or heart failure symptoms such as trouble breathing, poor feeding, growth, excessive sweating, low blood pressure, or fatigue. I put this in here just so we're at least all on the same page in terms of when we're describing things such as heart failure, what we're talking about in children. So what I tried to do in this is, this is really the guideline, not the guidelines, the American Heart Scientific Statement is really written for a provider audience. And I tried to distill 12 of the more important takeaway points on from this scientific statement. So here, this is the first 5 of those 12. And during this, I'm going to emphasize this and try to put in place what's new, what's different, and why this is important. So here, this tried to say that there's important differences both in the various types of treatment for cardiomyopathy and heart failure between children and adults. And children's cardiomyopathy may have similar names to cardiomyopathies in adults, but they often have very different causes, different risk factors, different paths of progression, and different outcomes. When we started the pediatric cardiomyopathy registry, we started it. I know I was at Boston Children's at the time, and we published several papers that when we looked at children presenting with heart failure with dilated cardiomyopathy, in that era, we were treating almost all of them with onotropes. Those are medicines to force the heart to beat with greater force. What we found and published in several peer-reviewed papers was that the biopsies of the heart or the explanted heart or the autopsied heart from these children that didn't have great outcomes, over half of them had mutations or deletions or abnormal function of their mitochondria that generate energy to the heart, and asking them to work more forcefully. What we found, it wasn't beneficial in many cases and hastened their demise. So when we started writing the grants for the pediatric cardiomyopathy, our premise was getting more to the understanding of the different causes will lead to more specific treatments that might really be beneficial to those populations. So again, the third bullet here that we really emphasized in this American Heart Scientific Statement is many of the causes of cardiomyopathy in children are related to genetic abnormalities rather than many behavioral or environmental risk factors in adults. What do I mean by that? Well, the fourth bullet, in general, children don't have chronic smoking, longstanding obesity, type 2 diabetes, alcoholism, long-term high blood pressure, or family history that can lead to cardiomyopathies in adults. In fact, we published from the Pediatric Cardiomyopathy Registry several papers that when we looked at real-world practice in North America, looking for metabolic and genetic and other causes of cardiomyopathy, including infectious, there's a tremendous opportunity to investigate that further, understand the causes more, and have more tailored therapy. So our fifth bullet on this slide is, as a result, treating heart muscle disease in children is often much different than in adults. Our next 3 of the 12 takeaway points from this statement are because many of the causes of cardiomyopathy in children are related to genetic abnormalities. What I'll show you a little bit here is what the scientific statement writing committee independently concluded is genetic testing of all children with cardiomyopathy is prudent and likely to have clinical value. and such genetic screening may result in financial and emotional saving. The eighth of the 12 points that the scientific statement brought up is treatment should again include personalized therapies based on the root cause, the symptoms, and progression of the condition in each child. And these treatments that are tailored to the root causes of pediatric cardiomyopathy may range from, in some cases, replacing missing enzymes to heart transplantation. Now, this was one of the papers that the Pediatric Cardiomyopathy Registry published in the Journal of the American Medical Association. This was supported by the National Heart, Lung, Blood Institute and strongly supported by the Children's Cardiomyopathy Foundation. So again, if you wonder what the contributions that you may make to Children's Cardiomyopathy Foundation do, you'll see a number of the reasons here. Before we did this, a number of textbooks in pediatric cardiology referred to dilated cardiomyopathy, DCM in the header here, as a disease. It's a phenotype, but it's many different causes, many different diseases. And what you saw here is that if a child presented with dilated cardiomyopathy and it was familial, even 10 years later, there was survival of about 90%. If somebody presented in childhood with a dilated cardiomyopathy, in the bottom panel in red, and it was associated with a genetic neuromuscular disorder, there's only about a 30% survival. And whether the cause was idiopathic, myocarditis, neuromuscular, familial, inborn errors of metabolism, or dilated cardiomyopathy in association with a malformation syndrome, the survival and clinical course were very significantly different. So it emphasizes the importance of really getting to the cause. And this work couldn't have been completed without support from CCF. Another one of those studies that the National Heart, Lung, Blood Institute supported strongly along with the Children's Cardiomyopathy Foundation. In the last slide, I was showing dilated cardiomyopathy. But here, this is some of the work that the Pediatric Cardiomyopathy Registry as a learning collaborative did for hypertrophic cardiomyopathy. And I'll use the example here. A family had a newborn boy with congestive heart failure, hypertrophic cardiomyopathy, meaning the walls of the left ventricle, pumping chamber were thick, and also had a dilated cardiomyopathy. So both HCM and DCM with reduced fractional shortening and dilation of the left ventricle. The father had clinically unsuspected hypertrophic cardiomyopathy on screening. There was a successful inpatient response in this newborn with heart failure to anticongestive therapy. The hospital discharge to home occurred on day 10 of life. This patient had mild, non-progressive heart failure on anticongestive therapy at home with slow weight gain. Developed upper respiratory infection symptoms at 2 months of age and had a sudden death at home 2 days after the onset of symptoms. And what we had done here in the registry is we took all the kids, all the children with hypertrophic cardiomyopathy, and we segregated them where we didn't know the cause, idiopathic, age at diagnosis less than a year, idiopathic, age at greater than a year, hypertrophic cardiomyopathy with a malformation syndrome, hypertrophic cardiomyopathy in association with an inborn error of metabolism, hypertrophic cardiomyopathy mixed with restrictive cardiomyopathy, and hypertrophic cardiomyopathy mixed with a dilated cardiomyopathy. The red circled box indicates that's what this newborn had, mixed hypertrophic and dilated cardiomyopathy. And then we looked in our multivariable statistical analyses. If a patient had no risk factors, what was the probability of death or need for heart transplant? If the patient had one risk factor for each of these areas or had two or more. So in this particular case, the risk factors that were statistically significantly associated with failing medical management, dying, or needing a heart transplant were decreased weight. And this particular patient in yellow had slow weight gain, congestive heart failure at diagnosis, which this patient had, and increased the left ventricular septal thickness, which this patient had. With those three, this patient had a 57% probability of failing medical management within a year and dying or needing a heart transplant. And that becomes important. Again, this family lost, a child that what we found here is that in the same study, heart failure, low weight, age at less than a year, or more abnormal echo measures at the diagnosis of HCM predicted poor outcomes. And multiple risk factors at diagnosis have the worst outcomes for most causal subgroups. So again, having had this type of research, it enabled us to say, gee, somebody like this, in the time when we did this study in 2013, wasn't that common to take a child with hypertrophic cardiomyopathy as a newborn and enlist them for heart transplantation. But this suggested that that was a very high risk patient. And what we found here is prognosis was worse with inborn errors of metabolism. Again, as you can see, 89% failed medical management within a year with two or more risk factors, and or with mixed dilated or restrictive, where 71% failed medical management within a year. And so what this says is infants with two or more risk factors at diagnosis should be considered for transplant listing, and heart failure, low weight, extreme echo measures at diagnosis associated with greater risk of death or heart transplant. And our feeling was this: we wanted to have things that could help children and families really right at the bedside. So our feeling was we didn't want to do research for the sake of research, but we wanted to have something here where clinicians could estimate the risk for death or transplant based on etiologic subtypes, that's these 6, and the number of risk factors at diagnosis. Again, those are those risk factors by cause down there. So it's another example where having a registry supported by the Children's Cardiomyopathy Foundation and the National Heart, Lung, Blood Institute helps better decision-making be more informed by real data, by working together. And another thing that came up, you saw in the first 8 of the 12 major takeaway points from this American Heart Scientific Statement, was how important young children presenting with cardiomyopathy have genetic causes. So one of the things that the NHLBI and the Children's Cardiomyopathy funded for the Pediatric Cardiomyopathy Registry was a study called the PCM, Pediatric Cardiomyopathy Gene Study. And we have just a wealth of talent and experience in our registry investigator group. And this was led by Dr. Stephanie Ware, the chair of genetics and genomics in Indiana, and was also led by the strong genetics group at Columbia at the time, led by Wendy Chung, who's the chair of pediatrics at Boston Children's, and their whole involved teams. One of my colleagues, Dr. Jeff Tobin, who helped found the PCMR with me, was also very much a leader in the genetics, as was Teresa Lee and others with strong genetic background. So our feeling was when we got this large grant that there was a critical need to determine the genetic causes of pediatric cardiomyopathies to tailor therapies and counsel accurately. And so this PCM gene study, again funded in part by CCF, identified genes that cause or variants that were associated with and may modify cardiomyopathy in children and influence the cardiomyopathy course over time with the hope of improving disease prevention, surveillance, early management, and prognosis. Our feeling was that if we can have better understanding of the genetic factors associated with cardiomyopathy in childhood, this may allow assessment to determine if personalized therapies based on the root cause, symptoms, progression of the condition in each child results in improved outcomes compared with conventional therapy. And although I'm showing this work, the scientific statement writing committee of the American Heart analyzed not only the PCMR study, but the work of many wonderful groups around the world in this area. And that's where the conclusion wasn't just based on one study, but the global research in this area. In this particular study, we performed gene exome sequencing in 528 pediatric patients with cardiomyopathy and their families from 14 U.S. academic pediatric centers over 10 years. And what you see in the cartoon is in this study, we also compared it to the 1,000 genomes in the Spark databases. And we looked at clinically identified pathogenic and likely pathogenic variants. And we found that 32% of children were affected. And then we informatically identified damaging variants. So that was an additional 33% of affected children. So this gives a feel that between those that have definite or likely pathogenic variants and those that have variants and genes that are probably damaging, more than 50% may carry a genetic predisposition. And when we said, who are these 528 children with cardiomyopathy in this study, we found that 50 to 53% had dilated cardiomyopathy, 30% hypertrophic, 6% restrictive, LV non-compaction, 10%, and mixed, but with 1%. And the average age at diagnosis for all was about 3 years of age. For dilated, it was about a year. For hypertrophs in this study, it was 11 years of age, restrictive 8 years of age. And family history of cardiomyopathy overall, when it was looked carefully, there was a pedigree, was positive in 36%, and it varied by diagnosis, as you can see. And so the first results slide is rare and damaging mutations were significantly more common in pediatric cardiomyopathy. So just to review what I went over on the other slide, 32% of children with cardiomyopathy had at least one genetic cause identified, but many mutations were found. And for 56% of these affected children, the genetic variants were known to be rare and damaging gene mutations. These rare and damaging gene mutations were significantly more common in children with cardiomyopathy than in our control populations of children without cardiomyopathy, and that was very statistically significant. The work from Dr. Ware, Dr. Chung, and others as part of this, in this second result slide, show that children's cardiomyopathies may have similar names to cardiomyopathies in adults. However, they often have very different causes, different risk factors, different paths of progression, and different outcomes. And now in this study, we showed they have different gene mutations. So the treatments in children must be tailored to the root causes of their cardiomyopathy. So again, the first bullet here is many different gene mutations can result in cardiomyopathy in children. And the gene mutations found in children with cardiomyopathy, although having some overlap with the gene mutations found in adults with cardiomyopathy, often were quite different and at times unique. And I show that here in table 2. This is the difference in genetic causes of cardiomyopathy between children and adults. So what you can see here, these are some of the gene mutations in adults with dilated cardiomyopathy. 10 to 20% might have a Titin TTN type mutation. Is only present in about 3% of children with dilated cardiomyopathy. And as you go through this, you'll see that children are not just small adults, to use an often quoted phrase. In our third set of results, we also found that infantile cardiomyopathy, that means when a child presents during infancy, the first year of life, there's much more potential for gene mutation discovery than in older children with cardiomyopathy. In other words, for children newly diagnosed with cardiomyopathy beyond the first year of life, 40% had a gene mutation identified. But for children in the first year of life, it was only 20%. And yet that suggests to us that if we were just touching the tip of the iceberg, so to speak, with this, and that there's many more important mutations that we'll find genetically in these very young children that present really very sick early in life, that knowing their mutations will help us have directed therapies. We further found that for pediatric patients with cardiomyopathy, the patient's ancestry matters. Although there are some shared genetic causes of cardiomyopathy in children across ancestries, some common causal gene mutations may be ancestry specific. So again, in the work that Dr. Ware's group and Dr. Chung's group did as part of the PCMR here, one example is the heart damaging gene mutation, myosin binding protein C3, which is a relatively common cause of cardiomyopathy in children of European ancestry. It was absent amongst individuals of African American ancestry, and that difference was statistically significant. And so some of the conclusions we took from this 10-year study funded by the CCF and the NIH was we showed that congenital the pediatric cardiomyopathies, abbreviated here as CCM, is a heterogeneous genetic disease correlating with clinical phenotypes for risk stratification and hopefully improved management and therapy. For example, based on this study, we cannot treat a 1-week-old African-American baby girl with the same therapy proven in a 75-year-old white man because the causes of their cardiomyopathy are likely different, and there are also race, gender, and age factors to consider in planning treatment. And the implications of this genetic work supports the use of genetic testing of all children with cardiomyopathy and suggests this will have clinical value. And such genetic screening may result, as I had said earlier, in financial and emotional cost savings. For example, based on the results of this study, now only asymptomatic family members of a child with cardiomyopathy with the same familial cardiomyopathy gene mutation may need to receive expensive serial cardiac surveillance studies to look for the development of cardiomyopathy instead of all first-degree asymptomatic family members. Just one example, there's many others. So now, since that's a little bit of the background of what the CCF has supported in terms of leading to the American Heart recommendations about genetic screening, these are the 5 remaining takeaway points, and this relates more to treatment. So these 4, it says 5, but it's really 4. treatment may be initiated in some pediatric patients who are at risk for cardiomyopathy before they develop symptoms to diminish the progression of the disease. Again, there was enough compelling data that the working group felt that you don't need to wait till a child is very symptomatic. The second bullet, adult heart failure treatments have limited effectiveness in pediatric dilated cardiomyopathy, and I'll show examples of this in a minute. Yet there's some evidence that suggests that short-term, their use has contributed to a decrease in the death rate among children with this condition. The third bullet for therapies is therapies to prevent sudden death in children with hypertrophic cardiomyopathies, including exercise limitations or an internal defibrillator, continue to evolve and have age and size specific parameters compared to adult treatments and devices. The fourth treatment point that the group felt the consensus on was a heart transplant is an acceptable treatment for end-stage pediatric cardiomyopathy, while ventricular assist devices are commonly used as a temporary measure while awaiting a heart transplant. The devices are associated with a low rate of ventricular recovery, like the results among adults. And one of the things that the committee put together was this central management and treatment illustration. So if we start in the upper left corner, if you're a provider of care for a child that you suspect might have cardiomyopathy, an important history and physical examination evaluating for signs and symptoms of cardiomyopathy and obtaining family history lead to a more timely diagnosis. Too frequently, these symptoms are attributed to infectious or pulmonary or other symptoms, and treatment is delayed. So really looking at this carefully becomes important. And then determine the cardiomyopathy phenotype. If you think there's suggestion of cardiomyopathy, dilated, hypertrophic, LV non-compaction, restrictive, arrhythmogenic. And then really trying to then investigate etiology. Again, when the PCMR spoke to pediatric cardiologists around the United States, we published that everybody said that they really evaluate comprehensively. And then we looked at people's actual patient records and charts. And what we published was that for the majority of patients looking for metabolic or mitochondrial or neuromuscular was really quite limited. And if they had been done even more in a basic way, considerably more diagnoses would have been established, which would lead to, that's where this becomes important, an increasing number of etiology-specific treatments are available. I'll give a couple of examples here, but in the scientific statement, the committee identified just in the next 5 years, this is going to be such an exciting area. There's at least a dozen etiology-specific therapies that are either active or approved or in the pipeline, more to follow. The feeling is if one understands the etiology, then one can determine some risk stratification. What's the risk of arrhythmia or sudden cardiac death? How about risk stratification for exercise tolerance? How about laboratories for end organ function or myocardial myocyte stress? Serial imaging needs changes, who's more likely to have changes in terms of recovery or progressive decreased function by echo or fibrosis with MRI or need for diagnostic caths. And then based on that, treatment more tailored based on the cardiomyopathy phenotype, the cardiac pathophysiology, and the clinical milieu become important for determining and sorting out patients who may be at risk for developing cardiomyopathy phenotype negative, for example, might be genotype positive, phenotype negative. Second, asymptomatic patients with cardiomyopathy phenotype positive, but mild, or symptomatic cardiomyopathy or end-stage cardiomyopathy. So one example that we published was we looked at taking an ACE inhibitor called an enalapril, an afterload reducer, and giving it to children that had dilated cardiomyopathy from having received cancer therapy. And initially, we were really pleased to see that giving an ACE inhibitor, similar to adults with heart failure, almost immediately led to improved dimension of the heart, less dilation, improved fractional shortening, and mass. But it wasn't sustained long term. In over 6 years, all deteriorated between 6 and 10 years, and the treatment effect was lost. And other parameters, such as the ongoing decrease in health of the muscle cell contractility and loss of muscle, apoptosis and like with reduced wall thickness, continued. And all patients with heart failure, when they started it, improved initially, but all had died or needed a heart transplant by 6 years. So our conclusion was improvements in left ventricular structure and function induced by an adult anti-congestive therapy, an ACE inhibitor, an enalapril, were transient, and that the primary defect, which was LV wall thinning, continued to deteriorate, and thus the short-term improvement was mostly related to lowering diastolic blood pressure. We and others have shown the same thing with beta blockers. So trying to understand the causes, trying to treat the causes, trying to prevent the causes become important. So one of the agents that we did a lot of work with, probably over 100 papers in the last 30 years, is an agent that we feel protects the heart from damage from chemotherapy in healthy children that don't really have a heart problem to begin with. They get diagnosed with cancer, they're getting chemotherapy that damages their heart. And we found that this agent in our preclinical studies and in our clinical studies binds to iron before the anthracycline chemotherapy enters the cardiomyocyte. So this is it. This is the cell membrane of a cardiomyocyte. This is iron contained within the cardiomyocyte. And what we found was the binding to iron prevents the formation of iron anthracycline chemotherapy complexing, which creates a free radical that damages or kills either the mitochondria or the actual myocyte. So as you look at this cartoon, you'll see the dextrazoxane goes in, it binds to iron. The chemotherapy comes, it can't bind to iron. And as a result, there's reduced cardiomyocyte apoptosis. And we published 18 years later, those children that got this dextrazoxane had statistically significantly healthier hearts. And that was shown in this paper and others we published just in the last few months, that this didn't interfere with cancer chemotherapy, and it led to significant improvement in not having ischemic heart disease, cardiomyopathy, cardiac death, and improved echo function. These are just some examples of the exciting things on the horizon. Increasing number by knowing the genetic etiology or the metabolic or other etiologies of the cardiomyopathy. There's an increasing number of clinical trials for pediatric cardiomyopathies and others. These are just 4 examples. There's been just so much great work in muscular dystrophies and in other areas such as Danon disease and in others, but there's so many more in the pipeline. But again, understanding the cause of the cardiomyopathy allows these tailored and targeted therapies. This is just an example cartoon. It's absolutely not intended to be comprehensive, and I don't want to offend any groups or companies that are actively in trials, and there's a number of them. One of the things we focused on, this was a study we did with a tremendous amount of support from the Children's Cardiomyopathy Foundation, was can we if we have 100 children and we know they all have the same cause, and we want to put them in a clinical trial of a tailored therapy, ideally, we'd like to know which children are most likely to recover versus which children may have end stage burnt out myocardiums and are less likely to recover. We'd like to have that opportunity to promote recovery. So in this particular study, again, funded by the CCEF and NIH as part of the PCMR, we found that there were distinct proteomic biomarker profiles that were extremely different between adults with heart failure and DCM and children with heart failure and DCM. But even more interesting, within the children with DCM, there were 4 distinct patterns that could be identified with up and down regulation of proteins that in these patients that could predict or go along with who was likely to recover versus who was likely not to recover. So again, multi-omic approaches of validating biomarkers that predict outcome help us again strategize and tailor some of these new and novel therapies and really help predict. So, and that's where for a rare disease, again, today's Rare Disease Day, no one center sees enough of the patients with pediatric cardiomyopathy. And so having registry-based research allows the innovative use of multi-center registries and adaptive trial design to have the potential to advance and refine future cause-specific therapeutic options for pediatric cardiomyopathy. And second bullet is pediatric cardiomyopathy data is collected and shared. The future is promising. What do I mean by that? This is another really important study, in my opinion, that the CCF, Children's Cardiomyopathy Foundation, and NHLBI did. The Pediatric Cardiomyopathy Registry, for, like I say, for 35 years now, has had a learning collaborative strategy. We share data, we meet regularly, we have Zoom calls face-to-face, and we get a feel similar to what happens in pediatric oncology, cooperative groups, and others, what are best practices. And what we found was from the 1940s to the late 1990s, when we looked here at really death or transplant, and we looked here years since cardiomyopathy diagnosis. And the blue are the kids that, this is when they were diagnosed, that normalized. The red dashed line are the children that needed a heart transplant. The third line, the broken dashed line, are those who died, and and this is the ones that were persistently abnormal. What we found was, again, in the era from 1990 to 1999, 20% of children newly diagnosed with hypertrophic cardiomyopathy failed medical management and sadly died. And what we found was, in the most recent era, for PCMR centers, part of the learning collaborative of best practices, that was cut by 50% with only a 10%. So the PCMR learning collaborative strategy resulted in a 50% improved survival for children with dilated cardiomyopathy in the most recent era, due to factors not associated with heart transplant. Again, the heart transplant rates were about the same and between different eras. So again, registry-based research for rare diseases, in particular pediatric cardiomyopathy, is really having a beneficial, positive impact. So some of the conclusions I wanted to bring up here is there are differences between the types and treatments for cardiomyopathies and heart failure in children and adults. Treatments in children can be informed by results of studies in adults, as well as by new mechanistic-based therapeutic targets identified in preclinical studies and tested in humans through phased clinical studies. Learning networks and registries focused on pediatric cardiomyopathies and heart failure can optimize data collection. There needs to be platforms for research and the infrastructure needed to implement quality initiatives. Again, there's still such a continuing need for some of you capable of helping to support the CCF, which really makes a huge difference in the advances we've had. We appreciate, and that continuing support becomes important. New clinical trial designs, validated clinically relevant surrogates, and composite outcomes suitable for smaller and shorter studies in children should advance therapeutic outcomes. And advancements, as I tried to give a little glimpse in precision medicine with the development of cause-specific therapies, should advance our ability to diagnose and treat cardiomyopathies in children. And so again, where we stand today is we've learned a lot, but in terms of etiologies, mechanisms, risk factors, clinical course outcomes, and all the rest, it's incompletely understood. Leveraging adult data in the absence of pediatric studies may not be helpful, could be harmful, since children often have different responses. Where do we want to be? We want to develop effective therapies that can alter the course and prevent pediatric cardiomyopathy. How do we get there? Again, registries and translational approaches will help us develop new etiology-specific therapies. And again, some of the challenges, these are rare, often diseases, limited number of children. That's where the CCF Clinical Centers program is nice to help network centers to work together. We still have to find appropriate endpoints since many of our children fortunately don't die but live chronically with disability related to their cardiomyopathy. And we need to validate more of those surrogate endpoints, like I brought up the proteomic patterns as an example. And there's a need to determine what markers are the most predictive and helpful and serial ones and changes over time, because that helps us then identify the high-risk groups, especially those that might be likely to recover for targeted intervention and tailored therapies based on intervention. And those that have persistent abnormalities, genetically based or toxic-based mitochondrial abnormalities, really need to be identified, because conventional therapy could make them worse rather than better. And trials comparing the management guided by these biomarkers should be compared to see if biomarker-guided therapy gives better outcomes than conventional management, and balancing the benefits and the risks of any new patient are critical. And so that's where not just prescribing new agents, but doing them in the setting of clinical trials becomes important. And looking at the effect of all of these, at the end of the day, what's really important for the child and the family is the quality of life of that child and that family over a lifespan. So if we say, what is the most important endpoint? That's it. So thank you. I'll take your questions.
We are going to open the questions now. A few have come in already. Go ahead and type in any of your questions into the box, and we'll get through as many as we are able. In the event that we can't, we will make sure that we get you an answer offline. So no worries there. Okay, so let's see. One question to start. Well, you're also getting a lot of accolades, so thank you for a great presentation, Dr. Lipshultz. The first question that we have to start is going back to one of the takeaway points about exercise and restrictions for hypertrophic cardiomyopathy patients. Does obstruction impact the strategy for those patients, whether they have HCM with obstruction or non-obstruction?
It's an excellent question. And it's a question that providers taking care of children and adolescents with hypertrophic cardiomyopathy have wrestled with for decades. Years ago, we would just restrict everybody. And some of the Bethesda criteria years ago really just said avoid all competitive sports and really strong athletic restrictions. We like to have children achieve their greatest potential with the least amount of risk. We find that one of the things CCF supported and one of their senior scholars just published just a few months ago was a 10-year study looking at children with hypertrophic cardiomyopathy. And although you bring up obstruction, one of the things that we found was a surprising high number of young children with hypertrophic cardiomyopathy have fibrosis in their heart, have scar tissue, even at the earliest stages. Not everybody has this. Some do, some don't. Part of what's being studied right now, again, is which children, which adolescents are at the greatest risk and what are the risk factors of exercise. Yes, it could be obstruction. Yes, it could be medication use. Yes, it could be related to the amount of fibrosis. Yes, it could be hypertrophic cardiomyopathy in the setting of ventricular dysfunction or hyperdynamic. And right now, quite frankly, it's a very active question. It's being studied by at least 4 or 5 major grants and studies. And if we had the magic answer, I'd be telling you we don't. But again, that's part of the need for more research. Great question.
Great, thank you. I'm going to combine two questions because they're both related to genetics. So initially, if a family, what would you suggest to a family who may have inconclusive genetic results as far as repeat testing and just continuing to look for answers with that? And then secondarily related to genetics, are there any promising genetic treatment candidates on the horizon in your opinion?
Yeah, so the first is, in fact, just this week, the CCF and the PCM are under the leadership of Teresa Lee at Columbia, putting in a large NIH grant just to look at children with cardiomyopathy that have variants of unclear significance and what that means, and if these things are inconclusive or even negative. The other thing that I showed from the study we did was in the newborn period and in infancy, the first year of life. We're probably, what we screen for, what we look for, only identifies some of the variants and some of the mutations that are more common in adults or teenagers. And as we can look more carefully, we'll understand which new mutations that we're discovering now with gene discovery may be more likely to be pathologic and lead to symptoms even in the first year of life. So again, it suggests that there's a lot more that we need to do, and that's where, in answer to that first question, we really recommend working with cardiologists that work with their genetic colleagues, because what we find is what we think is the absolute truth 1 year, 3 years later, there are sometimes changes. Some things that were variants of unclear significance then morph into being actually a pathologic mutation, and it can go either way. And then the other question about therapies, I showed several examples of gene-based therapies that are actually already in clinical trials, in some cases with really promising results. But these are for certain rare diseases where the exact mutations are known and there's probably in the next 5 years, at least a dozen more areas where that'll happen. The other thing is right now around the United States, we're testing on Rare Disease Day. It's worth me bringing this up, for on average about 30 genetic conditions as part of newborn screening. We probably have the ability to screen for several thousand. And as we identify more of these entering the panel, will be some of the pediatric cardiomyopathy genes, so that if we see mutations and we have a genotype positive, phenotype negative newborn, we will be able to perhaps, there have been certain clinical trials, we've been fortunate to be part of some of them, where we've been able to delay the expression of a clinical phenotype by knowing the etiology and knowing somebody has the gene mutation and to delay progression. But much more of that work will be happening. Again, if we can prevent disease or cure disease before it happens, that becomes really important. We're seeing more and more of that in some of the pediatric hematologic diseases and metabolic diseases, and neuromuscular diseases, where there's, by knowing the genes, there's potentially curative therapies.
Great, thank you so much. I know we're at time, but I'm going to just try to squeeze one more question in, and then the remaining questions we'll handle offline. For a family who may be interested in participating in a registry or learning more information about it, where would they go for next steps?
Well, I think that that's one of the reasons why the CCF exists, because for families that really are interested, it's a clearinghouse. And I've been privileged since Mrs. Yu and her colleagues started the CCF, for helping to lead the medical advisory board and the like, in response to parents and families saying, gee, are there centers of care that are more comprehensive around the country? That's why CCF embarked on this. So one of the things that in this ever evolving, changing field is what trials are up and going, which trials might be recruiting, and where are the centers that are participating. Right now, there's another trial in certain children that might qualify with hypertrophic cardiomyopathy for mavacamten. And there is a real pipeline of this. So for both treatment and for registry-based research, if you really are interested, just reach out to CCF, and they'll work with me and our medical advisory group and try to see if there's ways we can help.
Great. Well, thank you so much. I just wanted to thank you again, Dr. Lipshultz, for a great presentation and sharing your time and expertise with us. And I will close us out by just letting you all know that this recording will be available in the coming days, so we will be sure to send that out via email to you all. And we'll also include the links to the paper that Dr. Lipshultz referenced here today, and one of my colleagues could also drop that in the chat for everyone's reference as well, but we'll be sure to circulate that. And then just a couple of reminders, please continue to follow us on social media for all of our updates and news. A couple of dates coming up that we wanted to share. We're going to be having a listening session on March 26th focused on care considerations from the patient and caregiver's perspective. So we'll be circulating more information on that. And then we're also collaborating with the Pediatric Cardiomyopathy Registry and Cincinnati Children's Heart Institute to host the 6th International Conference on Cardiomyopathy in Children on May 10th and 11th. So more information to come on that, but we wanted to put that on your radar and thank everyone for your time and attention today. Thank you again, Dr. Lipshultz.
Thanks.
Thanks, everybody. Bye-bye.
Bye.